Good afternoon, everybody. Welcome to the fifth and final session of Virtually CAHSPR. This session is entitled Putting the Clothes on the Emperor, Opportunities for Healthcare and Research in the COVID Aftermath. This time slot is usually reserved for posters at the in-person CAHSPR annual meeting. And yes, as you enter the room, you receive a drink ticket. We haven't yet worked out how to provide drink tickets via Zoom, but those of you who are at home and feeling the need, please feel free to grab a drink, sit back, relax, and enjoy the session. As usual, I want to begin by acknowledging that we're on Indigenous lands. We need to respect the treaties that were made on these lands, acknowledge the harms and mistakes of the past, recognize the ongoing and present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, and government systems, and hope that we dedicate ourselves to moving forward in partnership in the spirit of collaboration and reconciliation. Virtually CAHSPR is a new initiative that will continue in the future. And to be part of any future sessions, you're going to need to be a member of CAHSPR. So if you haven't renewed your membership, please do so. And if you haven't ever joined CAHSPR, go to our website and join. You're very welcome, and you will get access to all future Virtually CAHSPR sessions. This session brings together discussions and lessons learned by incorporating the visions for the future that have been envisaged over the course of the conference. Stephen Lewis will build on the insights gained by encouraging participants to explore the opportunities that exist for the healthcare system and research in the aftermath of the pandemic. We want to acknowledge and thank the sponsors for this session, ICES. Remind you that you can write your questions using the Q&A section. The chat will not be open till the final 15 minutes of this hour. And I do ask that you use the Q&A tab just for questions and not for comments such as birthday wishes and telling me how erudite I've been. The chat feature will not be activated, as I said, till the last 15 minutes. The format for this hour is that Stephen will speak for about 15 minutes. We will then have a 15-minute Q&A on that first section of his presentation. So feel free to start posting your questions as he speaks. We will then close the Q&A and he will present the second half of his presentation and then have a second Q&A. The session will be recorded as of all others. And just to inform you, Stephen is speaking to us all the way from Australia. So we are very honored that you have agreed to do this for us, Stephen. Over to you.
Thank you. Okay. So, good evening in Canada. It's morning here, and I think it's afternoon on the West Coast. It's a pleasure to be able to do this. I'm delighted to keep my connections in Canada. I've been in Melbourne for 2 years, one more coming, and then back. So, my title talk is intentional about, and what is this all about? Why am I suggesting that the emperor needs clothes? Well, I think the metaphor is apt for a few reasons, and again, I'm not going to reread what you can see on the screen. I think in a nutshell, what the pandemic has done is it has revealed the cracks in how the world organizes itself economically, politically, its interdependencies, some good, some bad. And as far as health and healthcare, I don't think that thoughtful people in the epidemiological community, the public health community, and in the healthcare community were unaware of the potential risks of a pandemic. I think we were aware of the capacities that we did not invest in And again, we can have a conversation about why we didn't. Suffice it to say, I think these are as much design failures as being caught blindsided by things we couldn't foresee. And of course, one of the great tragedies of the pandemic, like so many healthcare tragedies, is that they strike the already disadvantaged worse. So there's a moral aspect to this that I think is troublesome. So what I'm going to do in the next 10 minutes or so, or 12, is to outline what I think the implications are for healthcare. And just to be clear, I am not an oracle or a seer. I don't know what will happen. And I'm certainly not a determinist. I don't think anything is inevitable here. We have choices to make. And what I hope happens is that new conversations will not only take place while the pandemic is fresh in our minds and still upon us, but that they will take place afterwards, that we will do a bit of a reset for a number of reasons. I also think that the easy part of this is to identify what is no longer tenable as an approach to health and healthcare. What the replacements will look like is perhaps a little more obvious in some aspects than others, but again, I would welcome your questions, and we can have a dialogue on that as well. And I do think that the fundamental question is whether whatever normal we have, is its standard deviation going to be larger? That is the world going to be fundamentally more stochastic than it used to be? Are we going to have wild swings in all sorts of conditions, just like extreme climate events are becoming more common? Will extreme other sorts of events, including pandemics, be more common? If they are, I think what follows from that is, of course, that we have to take a different approach to solving them, which will have implications also for the research enterprise, which I will get into in the second half. So here is my little simple schematic about the world. So pandemic, that's where we are. Notice how the color matches my shirt. That's an accident. So one of the options is we go back to the old normal world, despite all the talk that this changes everything. As I will talk about later, not necessarily. Maybe even if it should change everything, it's quite possible we will go back to the old normal. Or we could have a new normal. And if we have an old normal, we have two main options. Healthcare doesn't change. And when I say that, I don't mean it doesn't change at all. I mean that generally the structures, form, delivery modes, and patterns of healthcare will change at their previous rate. There's new technology, there's some new practices, but by and large, especially in Canada, they don't change much. The only thing that changes is a certain amount of restructuring, but as far as the actual delivery of healthcare, it may stay the same, or it changes some, more than it used to. So the slope of the curve or of the line of change may be a little bit higher, and that's a possibility. But if we have a new normal world, then we have, I think, no option but to change some, that is, accelerate the normal rate of change compared to what it used to be, or it can transform. And of course, we've had calls for transformation for a very long time, but the odds of achieving it have been vanishingly small. And among other countries, I would say that Canada would rank near the bottom as far as its likelihood of changing without a lot of external stimulus from an unusual challenge. In other words, we will change when we have no choice. So, has it come? Has the time come? Well, the time not only has come, but it came a long time ago. All of these things are true. We knew them before. We didn't need a pandemic to reveal any of these things, and I won't dwell on them. But I think all of these things, at least in our community, the health services and policy research community, most people would say that yeah, there's nothing unusual about this, and they're not new. And I just would emphasize the last point, that if you want a strategy not to be prepared for a pandemic, then you should embrace neoconservatism and small government. Because one thing that you must do to prepare for unusual events is you have to make investments that you don't know will pay off, and you don't know when they will pay off, except someday. And you will have some infrastructure and capacity that will be necessarily idle because you need it to prepare for what's going to happen. So, and of course, we've heard with yesterday's report from the armed forces about the nursing homes in Ontario. I'm not going to paint them all with the same brush, but it is certainly a moral hazard when you combine the profit motive with the direct care of vulnerable old people. So again, didn't have to happen, but I think the odds of it happening, again, were a design feature. So what are our early lessons from the pandemic for healthcare? Well, one is, of course, there has been a massive and instantaneous switch to what was very slow to develop in Canada. From an estimated 1% of visits to physicians being virtual prior to the pandemic, estimates are as high as 80 or even 90 now. But it made sense before. Some of the best healthcare systems in the world, like Kaiser Permanente, were 60% virtual prior to the pandemic, and by all accounts, both patients and providers like it. We also know, alas, that pandemic control is crude and highly disruptive. And when I say it's crude, it means we have massive policy interventions. They're not very specific, they're not very targeted, because we didn't really know what else to do, and there didn't appear to be a viable option. And hence the enormous disruption to the economy. We've also learned, alas, that the intelligence system needs a lot of work. And despite the fact that Johns Hopkins and Worldometer and others produce magnificently daily updated graphs and charts and so on, we still don't have standardized ways of getting a handle on the actual rate of the infection. We know that we are not counting the deaths in the same way. There's definitely undercounting in some places. We have no reliable prevalence data. We have a huge over-reliance on case fatality rates, which tend to overstate the lethality. But of course, it varies hugely, not only, but primarily by age. So this is a problem, because we don't really have a precise estimate, although it's getting better, of the magnitude of the problem and its virulence that we're dealing with. And even though we make comparisons, and the data are virtually begging for comparisons when we read them every day, we're not quite sure that they're what they really mean. Because if you're in a country with a high rate of testing, you're going to have more cases, which is a good thing, especially if you're finding the asymptomatic ones, et cetera, et cetera. And of course, the other lesson we may have learned is we may finally top out on our golden century of life expectancy increases pretty much across the board and across the world. They have been leveling out for a few years now, and in some countries like the United States, they've actually been declining for a few years. But if pandemics like this are the new normal, and they come every few years, then I think at least temporarily that we may see a halt to that upward trajectory. We've also learned that, which I think is a great positive, that when faced with a crisis, humanity can mobilize and innovate pretty quickly. And at least in the Western democracies, but I think generally, people by and large in these circumstances trust their governments and do what's asked of them. What we know about adherence to protocols gives one reason to be optimistic that people will actually take it seriously. And I think the final point, it's an interesting comparison. I don't know how much has been spent worldwide preparing for a viral outbreak, but it is nowhere near this amount that was spent. I don't know how many of you can remember Y2K, when we thought the world would come to an end as the computer clocks ticked January 1, 2000, because the old systems were set for 2 digits and not 4. Nothing happened much. I think the expenditure did do some good. I think it's a bit of a myth that it did no good, but look how much was spent, $460 billion US to deal with that, quote unquote, viral outbreak. in the computers, and we certainly didn't spend that to deal with this, despite SARS, et cetera, et cetera. So I'm going to stop there, and let's throw it open for some discussion.
So, Stephen, we have a question from, that we'll start off the discussion from Etnamir, and he asks, what does an unusual external stimulus to promote transformational change look like? So your reference to that.
Well, if, for example, there is a sea change, which I'm not predicting yet for sure, in how, in standards for personal interaction, and especially for congregating in places like primary care clinics, there is no option but to do this delivered in a different way. Or, for example, if all of the people who are now newly exposed to virtual care say they really like it, gee, I didn't have to wait so long to get an appointment. I didn't have to jump in my car and drive across town and wait for an hour and a half because the schedule was behind. This is remarkably convenient. So this should be my new normal. Or, for example, if we have to predictably, at unspecified intervals, disrupt traditional or conventional and normal healthcare patterns, so that we do have to suspend elective surgeries from time to time because we need to reserve the capacity for a pandemic. Well, that means how you deploy and pay physicians have to change because it will be unstable. There will have to be some ways to provide some and retain some capacity, because while once we can deal with an essentially idle hospital sector for a few months, I don't think we can do that every few years. So how do we organize our capacity so that we can both make sure we have standby capacity for a pandemic, and at the same time we can continue some of those normal things? Those are just a couple of examples of how that would happen, but it really depends on whether or not, back to the schematic, whether we are in a period of new normal or not. And again, I think we don't have enough points in the graph to say that that is for certain.
So you highlighted that we've known many of these problems for a long time. Diane McKenzie wants to know, what are the institutional barriers to change or transformation, and how would you change that, or how could we change that, might be a better way of asking.
Well, again, I think if there's something good to come out of this pandemic, it will be on trying to learn the lessons from the creativity people have shown in making some changes. Now, it's a bit of a mixed bag here, because I think many people, certainly I would put myself in this camp, would say the single biggest transformation that we've needed in healthcare, and I'll just talk about Canadian healthcare for now, for the past few decades, has been in primary care. It needs to be more comprehensive. Primary care physicians have to be part geriatrician and part coach, given the aging of the population. It needs to be more interdisciplinary. Needs to be more engaged and interactive so that people own their own circumstance. So we've known this for a long time. It's been talked about for a long time, and there are some excellent pockets of innovations. It just never spread. Now, in a sense, primary comprehensive care is a long-haul proposition, and it's not really the key to dealing with a pandemic. And if pandemics are the new healthcare threat in the foreseeable future, and every 2 or 3 years we have another one, then it may be that the primary care has to change in other ways, and it has to focus a lot more on a population perspective and the health of everybody, as opposed to just the individual patient perspective. And it may emphasize the behavioral aspect of this, because we have to adapt. There will be a mental health component to this, because I'm very concerned about the long-term and short-term, of course, mental health consequences of prolonged absences from or prohibitions of normal human activity, be it education or work or socialization. So that may change as well. These are the kinds of external stimuli that I think demand a change, because if you're going to meet people's needs, the needs will have changed. So and this will require, I think, some structural change, definitely some intellectual, conceptual change on what care is, and so forth. And conversely, on the other end, it may create a challenge for highly specialized care, because these new problems are going to be a lot more holistic. The mental health component will be even more central than it is now. The fact that you won't be able to plan for a lot of care the way we used to, again, because of the capacity issues and because of the need to mobilize healthcare providers to respond en masse to new challenges. This could be a major structural imperative that we have to go through, and I don't think its dimensions are clear.
So how do we become more nimble to make those kind of changes?
Well, that's an excellent question, and I think the one way you learn to be more nimble is to practice nimbleness. So I think health science education will have to change. You have to prepare people for major disruptions, that you cannot assume that you're going to have this stable role in a stable setting with a stable need for demand for healthcare appearing at predictable intervals. You're going to have to be a multitasker. You may have to be good at 2 or 3 things, because you never know what the next threat will be. I mean, maybe it's a pandemic like this. Maybe it's some other form of healthcare crisis that is caused by extreme climate change. Maybe it's a nutritional crisis because of threats to the food supply. Maybe it's a general mental health crisis because of a reorganization of the world's economy, or some factors that plunge the world into a recession, and you have to deal with that. So, and what's interesting is, I mean, the people who have to teach the nimbleness are, of course, predictably, faculty people who are more likely to be middle-aged and older, the least likely people to be able to adapt nimbly. So the nimbleness is all, in a sense, going to have to come from the learners as well, who interact with it. So it would be an enormous challenge. Again, I don't assume we have a new world that is unrecognizably different, but even if it's sort of new, then I still think we're learning that there is great virtue in nimbleness. And I guess the final thing I'd say about that, Alan, is, knowledge has exploded and the world has become hyper-specialized. I think this is yet another argument in favor of a return to a form of generalism, where people look at things more holistically and where you treat problems in a multidimensional way, including health and healthcare, combined with other dimensions of how we organize ourselves as a society, economically and so on, to deal with problems that are emerging from these sharp end causes.
So there are 2 questions that relate to international cooperation. Do we need more of it? And the other one is more specific, considering that you're down under right now. What lessons can we learn from Australia or New Zealand? And are their government leaders more appropriately clothed? Thanks for that one, Don.
Okay, so on the first one, I'm going to give you a short and simple answer to a very big and important complex question. My short answer is, we need more international cooperation, importantly, built on trust among trustworthy nations. So I think that there has to be a new pact here, a new signatories to a new treaty, in a sense, that says we're all in this together, and the first condition we all meet is full openness and disclosure. The World Health Organization has a presence in all of our countries. There are inspections. There is no concealing of any information. In other words, we agree to surveil ourselves on the common ground of full disclosure of what's going on, and we need to upgrade our practices in all sorts of ways in our standards, so that whatever public health consensus there is about how we ought to keep ourselves as safe as we can while keeping the economy running, we're all in this together. So I think there will be new alliances here, and I think people are learning who their friends are and who they're not in all of this. As far as learning from Australia and New Zealand, I would differentiate the two. I mean, Australia has done spectacularly well in terms of both its case counts and its fatalities, even somewhat better than New Zealand. I would give New Zealand the highest marks for the likelihood of it being cause and effect for policy. I think from the Prime Minister on down, it was the right thing to do. It was decisive. The communication was magnificent. I think Ardern has shone brightly through all of this. Australia is a federal system. The states and the national government they're no better at cooperative federalism than we are. And in fact, in some ways, I think Canada may be slightly better at it. At the very beginning, the Prime Minister here was not taking it as seriously as others. As far as I can tell, Australia did one thing right at the beginning. When it shut down travel from China, it did it decisively. And because it's an island and because they take no prisoners, actually they create prisoners, they actually quarantine you in an island. I think they did stop the flow of international cases quite quickly. And then the rest, aside from the cruise ship debacle in Sydney, has gone pretty smoothly. But my contention through all of this stuff is that the R squared of luck is probably 0.5 for every country's experience here. For example, in Germany, the first cases were middle-aged skiers who were healthier. In Italy, it was old people in a high-touch culture. So I think, yes, maybe Germany got on the testing a little bit quicker, but you know, the massive differences in death rates in Italy and Germany cannot plausibly be attributed to the Italians dropping the ball on all fronts or not having an advanced healthcare system, especially in the north where the country's more prosperous. So, you know, we always want to see cause and effect, but I think some of it is just dumb luck.
So you alluded to climate change a little earlier, and prior to the pandemic, I thought that we were in a situation where there was some momentum in Canada about understanding the consequences of climate change. I think there were some polls that showed that that was now becoming the #1 issue for many Canadians. What has this pandemic done, and is there potential to bring the two together as a motivation for transformational change?
I think yes, but the transformational change will be more in the economy. The interesting thing about it is the climate change absolutely affects the economy, but it does it a lot more gradually than a lockdown from a pandemic, which is going to is having catastrophic consequences that will play out for decades. And when I say that, I mean, for example, a large longitudinal European study found that a temporary period of involuntary unemployment in your first decade in the workforce, typically in your 20s, shows up 3 decades later as a 6 percentage point increase in the proportion of people who self-rate their health status as fair or poor. That is a massive effect that persists for 30 years, resulting from temporary unemployment in your 20s. So these effects are incredible. And what we need to do, and the stimulus packages have done this in a very, remarkably fast but also crude way. If the world is no longer a smooth and predictable place, we need to find ways to distribute the wealth to smooth out the crises. And that means we need to reorganize the economy in some fundamental ways. So yes, I think especially if we have a new normal where this keeps happening, the world will have no choice but to reorganize itself economically, reconsider its long and, in my view, disheartening recent history of making work ever more insecure, not only for people at the low end of the socioeconomic scale, but gig work for educated people moving from contract to contract. You may want to organize your work that way, but you can't organize your payment that way and your distribution of wealth that way, or you will have literally riots because people will be in a state of huge insecurity. So yeah, I think this is a wake-up call, and there's already a UN report out that talks about how you prepare the world's economy for a new reality. Those conversations, I think, are going to be extraordinarily important, and I don't think they will go away. The health part of this may go away. I mean, if we don't have another pandemic for 10 years, I don't think it's going to be top of mind for anybody.
So I've abused my privilege and asked you a few questions that didn't appear in the Q&A. We've got a few more here, so maybe one last one before we go into phase 2. And this is from Maria. Do you think COVID-19 will serve to undermine or strengthen public health insurance in Canada? And which health sectors do you see most vulnerable or buoyed by change?
Great question. Don't know. I think if I had to plop down money in with my bookie in Las Vegas, I would say it'll probably strengthen it a little bit. And I think the sector that will be the litmus test is long-term residential care. You know, again, given the incredible concentration of deaths in that sector, but more importantly, yet another round of revelations of how dismal the conditions are. I think my hope is that this now becomes politically important, and that not only the elderly and near elderly like me mobilize and make it matter politically if we're going to do this, but if you look at Canada compared to the Nordic countries, for example, we spend from a half to a third as much as they do on community and long-term residential care. And the biggest deficit is in community care and in the social supports that we give people to live a decent life in the community without putting so many into nursing homes and without conscripting their families to provide 80% of the care in the case of the community and 30% even in the case of long-term care facilities. So I think we'll see some expansion there. Elsewhere, again, depending on what the treatment scenarios look like for communicable diseases in the future, if they are primarily pharmaceutical, again, it strengthens the case for some expansion of pharmacare. But then, of course, if we want to act on both of those fronts, we have a prioritization problem, an allocative problem, and frankly, a taxation problem, because we'll need revenues for all of this. As is everything, these are democratic issues fundamentally, and when we've all calmed down and we're surveying the wreckage, then we'll see if the politics change and if there is some consensus, even across party lines, that we need to fundamentally do something and invest more. I'm not certain that we will, but I think there's a possibility. So I'd be cautiously optimistic that if anything, publicly financed healthcare will get a boost.
Very encouraging. Let's go into part 2.
Okay, so many of us here today are not only citizens who need healthcare, but we are researchers. So what does this say? And interestingly, I think the implications for research may be not only as big as they have been they may be for healthcare, the economy, but there actually may be a chance to make some major changes. So what have we learned? Well, we have learned that when push comes to shove, in the middle of a crisis, all of a sudden this incremental, slow, review-intensive, leisurely still process of getting insight into a project, into findings, into knowledge, into dissemination can be compressed spectacularly. I know Jennifer Zellmer in her presentation mentioned there are 11,000 peer-reviewed publications in this year alone on the pandemic. So I did these searches, And it's quite remarkable how many hits there were just in 5 months on that score. And interesting on the modeling, right? You know, there has been an explosion of models. In fact, that's an interesting research project in itself for the future about what was the impact of some of the early models on our perceptions of all this, because most of the models have been dire and their impact has been overestimated considerably. I'm not saying there's anything that was necessarily avoidable there, but 850 publications on models alone. And even, I mean, I'm sure many of you have gotten the call from a journal, can you review this in a week instead of the usual 3, or even in 2 or 3 days? So it's been quite a spectacular mobilization of intellectual effort and dissemination. And I commend the research community around the world for that. So this pandemic also raises a bunch of fascinating new research questions. Some of these are newer than others, but you can see them here. Since there's been an enormous interest in how individuals behave, like what is the average citizen going to do in the face of a pandemic? Are we going to estimate the risks properly? Are we going to do what we're told? What affects whether we're going to do what's asked of us in a pandemic? Does it change over time? Does a prolonged period of adherence to the prescribed behaviors without much happening in your community, certainly the Australian phenomenon where there are virtually no cases and no deaths, does people's propensity to adhere drop off? And if it does, is that a good or a bad thing? You know, is this a failure of people or is this a failure of policy? And then, as we were just discussing, how will the pandemic affect government funding priorities in the short and in the longer term? So these are some fascinating questions, and to answer them will take some very creative organization of the research enterprise. Just related to the COVID-19 story, as we talked about, what explains all of the variable experiences? You know, again, we keep saying that country did great, that country didn't, so country A is virtuous and country B is negligent. Well, we don't know. We don't know, and we don't even know which of the various approaches could plausibly be declared a cause of a good or a bad outcome. So we need to know. We need to know this for next time, because if I want to impress one point, it's that the cost of doing it the way we've done it this time is staggering, and it will persist over time. We shouldn't ever do it again unless we have no option. And we won't know if we have an option unless we know which of these factors matters and which doesn't, and whether we can be less intrusive than we have been in order to get to an outcome that we find acceptable. So that's a fascinating, I think, imperative that we have as a research community to unpack all of this. Following on the conversation about adaptation and resiliency and what's going to happen. So again, imagine that the world has to totally revisit how it produces, distributes, consumes, moves, educates, cares, etc. If we're going to do that, and if we're going to concede that a new normal is unavoidable, and it's a major new normal from the way the species has evolved and the way we have organized ourselves, we need to understand these things. How much is too much? How much change is simply unsustainable from a mental health point of view? We're a high-touch species, at least many people are, most of us are. So if permanent physical distancing and a general wariness and suspicion of gatherings and human contact is going to be embedded in our psyches, what impact is that going to have? Is there some way we can retain our humanity and our ability to love and form close relationships if there's this unavoidable self-preservation oriented distancing? It's a bit science fiction at this stage, and I, for one, am not going to give up on the prospects for not having to do some of those things, but the discourse is certainly out there already. As I mentioned earlier, smoothing out the economic effects of major disruptions to the economy is an absolute moral and practical imperative. It's a moral imperative because you don't want to leave people in a state of huge suffering. And I think the practical imperative is that if you don't smooth it out, you're going to have an extremely unstable world politically, because you'll have a lot of people with nothing to lose. If they have nothing to lose, then they're going to be disruptive in their own interests and so on. And even, you read these commentaries about, well, we can't pack subway cars the way we used to. Well, it'd be great if we didn't have to pack subway cars the way we used to. But the amount of investment it would take to move towards more people taking public transit, which is a good thing anyway, and making it a less dangerous, crowded, uncomfortable experience for both health and other grounds, that costs a ton of money. Are we prepared to do that? And this requires us almost to think of a lot of these things as essential public utilities, and we're going to nationalize a lot more of the economy if those new realities come about, if the standards have to change that much. Even the notion that, well, workplaces that we're going to have some distancing. Well, if you just suddenly declare as a matter of a public health standard that every office worker needs twice the amount of square footage as before, either everyone's going to have to work at home, or you've just created an enormous demand and need for and requirement for, in many cases, expensive real estate for an enterprise. So I think we have to think about these things and whether there are ways to adapt and to keep ourselves safe without these kinds of disruptions, many of which are impractically unaffordable if you take them literally. I don't have to convince this community about data design, collection, and use, but again, I think both worldwide and certainly in Canada, we have learned yet again that you need more and better longitudinal data. We need a more integrated data sets that marry biological data to all sorts of, to even survey data, to mental health data, and to healthcare utilization data. It's very interesting when and if the science community will unpack what it is about some people's genetics or physiology or biochemistry that makes COVID-19 more or less threatening to their health. Personalized medicine obviously comes into play here, but there is a remarkable difference in some people and apparently even in some jurisdictions in the lethality of the pathogen. What is it? And is there anything we can modify there? And of course, developing indicators that can be markers for earlier identification of risks and impact. Is there a science of earlier detection that might come from new and creative ways of sampling, doing biological sampling of the population? And what can we learn about immune systems and which groups may be more at risk in a future pandemic and which people may be less? And of course, the final one thing we know from the behavioral economics literature is that we humans are notoriously awful at risk assessment, both our own and in general. Well, we all have to get better so we don't overreact or underreact to major and suddenly appearing new phenomena that have a great deal of uncertainty built into them. So how does the public understand risks and trade-offs? Does anyone, if you say to the public, what do you think the short-term toll of COVID-19 will be, and what do you think the long-term toll will be, and what's an acceptable long-term toll that we incur in order to keep the short-term immediate impact of COVID-19 down? It'd be interesting to see what people say, and does it make any sense in a rational way? And how does our perception of risk affect our mental health and our behaviors? If we are extremely risk averse, or if we are the type who typically overestimate risk, does it make our life miserable? And if we underestimate it, does it make us put ourselves at risk in ways we shouldn't? So again, even fewer of you will remember this term. This was from the fall of the USSR when the Soviet Union collapsed. And the phrase was glasnost and perestroika, opening and restructuring. Well, it seems to me that the research community may be ripe for some opening and restructuring, because many of its processes are made for a world that changes incrementally, and where, if not at a leisurely pace, a steady, systematic way of acquiring new knowledge and deploying it is the way to go. That's how science works. Well, even if that's how science should work, and even if there is no conceptual, intellectual option to doing it that way, if the world is going to be facing cataclysms and huge new challenges that must be dealt with in real time, then we have to change the research, some of the research enterprise. We will need rapid response capacity to mobilize around getting the earliest available evidence and insight to decision makers, even if it's incomplete and even if it may be wrong. Acting on some intelligently acquired knowledge and insight and wisdom is a lot better than winging it completely. We may need this intelligence reserve army where all of us become conscripts, just like healthcare providers, to be doing something different when we need to get our act together in order to help the process of dealing with a rapidly emerging new threat. I think how we organize the research enterprise into centers and institutes, that's already starting, but I think it has to accelerate. There may be a big new discipline dedicated to the study of systemic shocks of all types. And it won't be just health and healthcare, of course. It will be, these are truly interdisciplinary, and these are truly multifactorial centers that look at these questions from their origins to how we deal with them to the aftermath in a comprehensive way. And again, we do a much better job than we used to of training researchers to work rapidly in teams and so on. But the old reward systems are still in place about what matters to your career development and how you acquire status and prestige and what your prospects for advancement are. Well, if it's a multifactorial world that takes dedicated and large and multi-site teams to mobilize quickly around answering particular questions, all of that has to change to some extent. It's not an enormous problem in a conceptual sense, but it is in a practical sense. And again, we have sped up the cycles for putting huge amounts of money on the table for people to get going, to find stuff out. This has been remarkable. In the aftermath, we'll have to evaluate it to see how well did it work. If it worked pretty well, then it says, well, maybe we got to change the way we normally do it, which is this labor-intensive, incredibly complicated, expensive way of getting a project designed, approved, and funded. You know, maybe we can accelerate that like crazy. And my final observation on this whole thing is that, yeah, sure, the new normal may be a prediction that we can't go back to the old way. We can't go back to the old way. Well, we have gone back to the old way a lot of times when we weren't supposed to. These are some examples. So I don't think we can say this changes everything. This might change everything. This should change some things, and some things should have changed before the pandemic. So I'm all for change, for useful change, for positive change. If some good comes out of this, if there is a major reconsideration in the world of, for example, economic relations, if we do create some new international alliances that make us more of a human family than we are right now, if healthcare starts to do some of the things more sensibly that it has resisted, such as virtual care for the many people who would welcome it and so on, that would be a good thing. But I don't think our structural and institutional framework is so fragile and brittle that it's going to disappear because of this. If this comes again in 2022 and another thing comes in 2024 and a worse one comes in 2026, yeah, that will change everything. But until we have a few more data points, I'm agnostic on it. And I think the fundamental human condition is we don't like change. Once we get half accustomed to something and we get reasonably competent thing, we like to hold on to it. So my hope is we don't have to change except when we want to, and in the ways that we've always wanted to do, but we haven't achieved yet. And so that if this and future shocks helps us to change in ways that we have aspired to in the past, that would be a good thing.
So lots of food for thought there again, and a number of questions. You did at the end relate to what probably most people would regard as an unlikely scenario of another shock in 2022, another one in 24, etc. However, should we be preparing for that? And if so, you mentioned the possibility of needing researchers who are dedicated to studying shocks to the system. What would the impact on that change be of recognizing the need for preparing for those repeated shocks on the system and then on the research world?
Right. So, I don't know how possible it is to prepare for these shocks to the system unless they all look like this. I mean, if the pathogens are fundamentally different, supposing the next one's a bacteria instead of a virus, how does that change things? So, I think when I'm thinking about the social science, epidemiology contribution to this, we need to understand, I think the big frontier there will be the mental health resiliency, adaptability aspect at both an individual and a community level. I think preparing ourselves and preparing young people, preparing kids for what does it look like when you have to do this, and can you prepare people for an unstable world if it's going to be unstable? I think that's an enormous challenge. I think we should do that anyway, frankly. I think mental health and resiliency have been emphasized as parts of growth and development in education, and I think it would be a good idea to start emphasizing it a little bit more. On the other end of it, I think the challenge is, how do you reduce the costs of dealing with these pandemics? I mean, again, I mentioned we've taken a very crude whole cloth approach, shut everything down and hope it works. Well, we're testing whether shutting everything down and will it worked, and yeah, it seems to. But the price is way too high to be doing this every 2 years. So how do we do it more efficiently? Well, so when we get the immunologists, the virologists, and the test development people, and the pharmaceutical industry to mobilize around this kind of thing. And frankly, I think leaving all of that to the private sector is a recipe for disaster. I think because this is unpredictable, and because you never know what the return on the investment is going to be, you need to mobilize a lot of public sector talent with government money to be working on these things all of the time. It's part of the capacity you have to build. You're building a levee for a hurricane that may never come. So you've got to build the damn levee, though, because you've still got New Orleans. And you don't want to let it go, even if it's 1 in 100. So that, I think, will be an interesting challenge. And I mean, I think I of all people have no clue what this should look like, but I think mobilizing the intellectual talent in various disciplines around these connections between markers, between individual and community level strategies for intervention, between figuring out, is the holy grail to get magnificent drugs, or is the holy grail to be able to fine-tune the immune system so that whatever comes at it, you can fine-tune it so you can fight it off, even if there's a big diversity in the population, especially among older people, where the immune system is compromised. And can you regulate the overreaction that has killed a lot of people of their immune system? It's sort of the same argument about cancer. You know, do you look for the master switch that regulates all cell replication and replication problems, Or is there no master switch? I mean, those are the kinds of things that will tell the tale. So again, optimistically, maybe in 5 or 10 or 15 years, we will find some master switches to this, so that while these things may occur, it will be much easier and more effective to deal with their impact, and you don't have to disrupt the world as much, because we will just, it'll be like penicillin for bacteria. You know, if there's a penicillin available for a lot of these things, then we have a temporary problem. If there isn't, and if the viruses get increasingly clever in their mutations and in their strains, then we have a perpetual challenge that could be increasingly worse, because at some point they may have the last laugh.
We're not going to end on that point, that's for sure. So one of the questions that I think is interesting is you related to the dramatic number of papers that have been published, the amount of research that's happened in such a short period of time. And some of that, I think, has been due to what the question says is, what might be the consequences of accelerating research processes on rigor? And I think some of those publications haven't necessarily followed all of the rigor. We saw some of the early stuff with regard to the consequences of hydroxy, and not only the political part of that, but there's been a lot of time and energy wasted, I think. So there's a danger with accelerating research processes.
There's a danger, frankly, in having 21,000 health journals in the world, most of which publish nothing of consequence ever. Yeah, we have an overproduction of mediocre and useless research. Now, the question is, can you improve the signal to noise ratio? Well, you sure as hell can't in the middle of a pandemic. But longer term, it's a very good question. Again, when you're in the middle of a pandemic, the question you posed is really, it's absolutely the case. A lot of wonky stuff that will prove to be, or has already proved to be, wildly unhelpful gets out there. The question is there an alternative? Like, is it better to have a bunch of noise because you're still going to get more signal with this process? And the trick is have better filters and have better have a better way to assess what's out there, and better techniques for finding the ore, the gold in the ore. Or is a lot of this just simply silly and we shouldn't ever do it again? I don't know the answer to that. It's a good question. But what struck me was, even if only 10% of it is useful, that's still a spectacular output in a few months. You know, that's amazing. That is amazing. And again, if I'm a decision maker, I would rather have that than people saying, look, it's even more important to be rigorous now. We're going to peer review the hell out of everything that is, especially the more provocative it is. They're going to make decisions anyway. So if our community wants to have some reasonable influence on decision makers, I would take my chances on overproduction, to tell you the truth.
Okay, one last question, Stephen. Clinicians are having an identity crisis right now, so they may be open to change. What would you ask physicians to do right now?
Well, interestingly, I think a lot of physicians are idle right now. They're doing less than they used to because patients don't want to come, and they are not redeployable in any useful way, partly because in some places there's not much need for redeployment, right? I mean, the numbers aren't high enough that there's really nothing to do. The public health is doing its job. So, you know, I think what physicians should do is contribute to the rethinking process about how medical education and medical practice ought to change in the future. It's a long thought process, but I don't think you can do anything else. There are no answers to be had here, but ask yourselves, Did you feel useful in the pandemic? Does it change your view of what you're doing and your role in the healthcare system? Would you like to do other things? Does it suggest some kind of new training that you would like to take? Do you think the organization of your practice should change? Would that be better? What did you find amid this crisis? Did you find some of it rewarding and interesting, and did it recharge your batteries? Or do you feel that the future of your discipline or your specialty is kind of marginalized if this is the new world? I think it's the same challenge of any other person in the healthcare system, right? Everybody has to rethink this, because in a way, if you take the doomsday scenario and that half of health in the future and half of healthcare will be communicable diseases of an unpredictable and virulent sort, then everybody's priorities change. I mean, what do you do? And then there's a balancing act, right? So how do people with cancer and MS and other chronic conditions, how do we continue to meet their needs at the same time as well? So I think this raises a whole lot of questions, some of which changes may never occur. But again, I think it's better to have thought about them and anticipated and formulated some kind of response to these things that might occur than only react when they do occur and shortly after. So again, I don't give you an answer. I'm saying think more about what you're doing. If you were in a silo, and if you thought you knew what you were going to be doing for the next 30 years, think again, and then think what you want to do.
I think that's a great point to end on, Stephen. Thank you so much. That was just a wonderful presentation. So my job right now is to close the session by thanking both you, thanking Sally and her staff at Face to Face, thanking Maggie for her outstanding leadership in putting together this virtual conference so quickly, thanking our sponsor for this session, ICES. I'd like to remind all of you who joined in that we will be sending out evaluation forms. So we really, really do want you to fill those in. We're looking forward to learning from this experience and putting on new future virtual sessions that we hope to grow and to learn from this experience. And we hope to see you all in Saskatoon next year for an annual conference. We're not quite sure what that will look like. Stephen's smiling, that's his hometown. We're not sure what that'll look like, but our intent is to be able to go to Saskatoon next year. There's lots of water to flow under the bridge before then, but hopefully we will be there and be able to actually do some of that more personal touch stuff that Stephen pointed out is so important to our mental health. We all need that human contact. And while I've enjoyed this conversation with Stephen immensely, I would have enjoyed it so much more over a glass of wine. Thanks, everybody. This has been amazing.